Well, good morning, everyone. Thank you for coming. This is an exciting week, and it's nice that you are all able to join us first thing this morning to get the week off to a nice start. We've been talking a lot lately about the new registry, and it's very new, it's very exciting. There's been a whole lot of time and effort and energy go into creating the new registry, and we thought it would be useful to useful exercise, bring everyone together, tell them about the registry, sort of walk you through it, show you what it looks like, so that if you, in your travels, are called upon to sell it to your constituent groups, you'll know what we're talking about. I would like to welcome and introduce Dr. Ann Stevenson. Dr. Stevenson, many of you may know, is one of the CF clinic physicians at the St. Michael's Hospital Adult CF Clinic here in Toronto, and is involved in 101 things, but in fact she also, which many people may not know, she is the director of the Canadian Cystic Fibrosis Registry. Of course, we have our Denise Mack, who is the manager of the registry, and I guess I'm the token boy, and I'll think myself with that. So when we were starting to develop this discussion today, what I was wanting to do was just sort of talk about the new registry, explain what's new about it, why it's so great, and move on from there. But in our discussions, we sort of realized that it might be useful to give a bit of background and a bit of context to the registry. So I'm going to talk a bit about the background, context, and so on. Denise is going to walk us through the new registry with screenshots and so on, so you can see what it looks like, with patient data blanked out, of course, because if you haven't signed the confidentiality waiver and you see patient data, we have to kill you. We don't want to do that. Then Dr. Stevenson is going to talk about the uses of the registry and why it's as valuable as it is. So just giving a little background, it's going to move soon, right? What goes on here? Okay, just move the slide ahead.
Yep.
Thank you. So back in the 50s, and there's going to be a change there.
Yeah, of course.
Anyway, I'll tell you anyway. So back in the 1950s, there was a pediatrician in Cleveland who saw CF children.
Yep.
Okay, so there was a pediatrician who saw CF children, and he was claiming that the survival rate with his CF population was 2%. The national average at that time in the United States was 20%. Now, this is all, I suppose, hearsay, but the point being, he was saying that it was 2% based on the rest of the country, which was 20%. And that's all well and good, but if there's no data, there's nothing to support that, there's nothing to substantiate, it was just sort of hearsay that he was coming up with these claims. We don't really know how that came about. So the American Foundation decided that they would give a grant to Dr. Warren Warwick, who was actually a very influential, very prominent CF physician at the time. They gave him a grant of $10,000, asking him to collect data from some of the care centers in the States. They call them care centers in the States, not clinics. I don't know why, but in any case. So they gave him $10,000. He collected data from 31 care centers and was able to prove that, in fact, yes, the group in Cleveland had a much better survival rate. Now, of course, we don't talk about survival rates or what does it say here, the mortality rates. We talk about median age of survival, but in any case, you get the point. There's a drastic difference there. When Dr. Warwick came up with the data, he did establish that, in fact, yes, the median survival was 7 times higher than any other clinic in the state. So with that data to prove it, it was able to substantiate the claim, which was kind of neat. So moving ahead. So anyway, in the 70s, the American Foundation approached the Canadian organization and said, do you want to contribute Canadian data to the registry? And absolutely, we wanted to do that. So we contributed to the database. It was now growing at this time. And in 1976, there was the first joint report from the American-Canadian experience representing data, CF clinic data from around North America. Then in 1984, oh my gosh, she's got it. There it is. Yeah, check it out. So
I have to get it rebound because every time I open it, one of these things comes out. But
it's so cool. So this was issued from the Cystic Fibrosis Foundation, 3379 Peachtree Road in Atlanta. That's where the American Foundation was at that time.
That's right.
Issued in 78, but this is a 76 report. If we can move to the next slide, it talks about. This is the table, this is the summary table, 1976 data, Canadian centers, 2,171 Canadian patients in 76. kind of cool.
So this is the Canadian.
This is the Canadian subset
Their
of the
2100 report.
2171, that's right.
Patient.
Yeah, so we're over double that now. This report, by the way, I mean, obviously you can tell this was generated on a device called a typewriter.
Like, look at these tables.
Yeah.
Your parents might remember.
Well, I was going to say that.
Oh, I remember.
Look at this. Imagine making a mistake.
I know. Tell me about it. Oh, my God.
A typewriter was
for white hair.
something that the dinosaurs used to use to communicate with each other. That's a breakdown. Interestingly, so now here, and you move ahead here, and I think this is actually really cool.
Actually, if you want to go back for a second,
Sure.
it'd be interesting to know if it's similar today. 52% are
Male
male,
is 52, yeah.
and 47, almost 48 are females. That's pretty much the same today.
Yeah, yeah. This is really cool. So, and then I really like the next one, the survival curve, because, okay, so we've got the Canadian experience is the solid line, the American is the dotted line, and you look at, so this is median age of survival, 72 to 76, so it's a 5-year window. We always report on a 5-year window. The individual years are just a bit too inconsistent and spiky, so we round it with a 5-year window. We've got, so the median age of survival, 50%. The Canadian experience here, roughly 24. The American experience, 50%, is about 18. So that shows us two really important things right there, which I think is really interesting. That proves to us that we know that the Canadian median age of survival continues to increase, and yes, we know that it's over 50 now. So this proves that back in the 5-year window, 72 to 76, it was that. This also shows that the American experience, for whatever reason, the Americans typically have much lower survival rates, and that proves this as well. So I mean, this graph shows us a whole lot with just a very simple, I think.
Now, the thing is that when we were Anthony and I were at the foundation, what we heard was that, oh, thank you. Would you like? They said that the reason was because in Canada we promote the high-fat diet, and in the States they're not allowed to. Do you know anything about that?
I don't really know that.
Isn't that something that I had understood, or maybe I misunderstood, or something along those lines?
They could use a hypothesis that we adapted the high-fat diet earlier than.
Oh, is it earlier?
I think.
Okay, maybe that's the case.
And I'm going to talk about that.
You're going to talk about that?
In a little bit.
For those of you who weren't watching closely, I just managed to make Denise squeal with glee by interpreting a graph.
What's the name of this graph?
This is a survival curve, man.
What's the name of, yeah. It is good, good.
That's what we're going. So all this to say that we've had this registry around, we've got data, I mean, we actually have data. We've got a few data records back to the 60s in the Canadian Registry, which I think is pretty incredible. It just sort of really picks up in the 70s and gets quite robust in the 80s. But the point being, we've got data back longitudinally for decades. And I mean, some patients in there, I mean, we've tracked their entire lives statistically in the registry from start to finish. So when I first started at this organization, which Mary was here then, my title...
Dinosaur.
My title was Patient Data Registry Assistant, and my job was data entry. I entered the data into the registry that was submitted by the clinics on paper forms.
Do you have a picture of yourself when you were that?
You have a picture of him back then.
Oh, did you put it up? Oh, I'd love to see it.
He was wearing a mustache.
That's the dirtiest look I've ever
Thank you. And so, I mean, obviously a lot has changed. What hasn't changed is the clinics still submit the data, right? Just to clarify, the patients own the data. It's their data. With consent, the clinics will submit it, collect it, and submit it to the registry. And then Cystic Fibrosis Canada, we're the custodians of the data. So it's the patient's data. They consent for the clinics to submit it, and we are the custodians. So another interesting point about this is you know that we provide clinic incentive grants to all the clinics. And we don't just give them that money. We actually ask for two things in return. We ask them that in accepting a grant that they will host a site visit periodically, and also that they'll submit data to the registry, because if there isn't a little bit of an incentive there, it's very easy to forget about submitting the data. But that's also how we ensure that the registry is as robust as it is, because clinics get the money from us, so they submit the data. That's how we make that happen.
At the same time, I have to say that not very many patient associations are doing this, first of all, as far as I know. Do we have record of anybody else doing something similar to this? Because this is really, if we talk about what differentiates us from other nonprofit patient associations, I mean, this is truly one big, and it's very patient-driven, very patient-focused, and very partner-oriented. I mean, there's so many things that is wonderful about this. Sorry, am I selling you?
No, this was misbehaving.
Oh, my goodness.
That's got to get passed around. You know.
Oh, my goodness.
Everyone calling in, Miss Inchley has lovingly shown proof of Ian.
In 1962. With a beard.
I wasn't even born in 1962.
You haven't changed, just your hair color is lighter now?
Lighter. Lighter. I've been lightening it, yes. Okay, so I will just finish up by saying, so moving on then, so the new registry, what's new about it is it's now, we don't submit it on paper forms anymore. It's all internet-based, so it makes it a lot easier for the clinics to submit the data. It's a lot faster once they get up to speed, I'm hoping. I think that will be the case. It's encounter-based, so there was a time that the registry, when a patient came to clinic the first time in the year, that data would be submitted to the registry and there was one record per patient per year. Now what happens is if a patient goes to clinic 6 times a year, the clinics can submit that data for 6 times, and it makes that patient's record so much more comprehensive. What else is really new about it? There's the reporting capabilities. Clinics can now create and generate their own custom ad hoc reports, and it's also now in French. En français, for the first time, our French-speaking colleagues can use the registry in their own language.
Oh, yeah, they can put it in their...
Absolutely, yes.
Excellent.
Some pages are in French, like the variables, which is where the variables are, and they enter it, that's in French, but not the whole.
Putting in the data is not in French.
When you log in, it's not in French. It's
No,
French pages, but only the pages where they enter their data, that's in French.
And this is the first time there's been any French in this.
Well, that's a
First
it's a good
time
start.
ever, yeah.
So is our goal to eventually get to a level where it is
Full bilingual? I think we'll have to see what the clinics want. Right? If they're okay with what it, how it is.
I mean, if they're okay with what it is right now, but I'm always very particular about that type of balance. And if we can move in that direction, that would be fantastic.
And we now are going to have the instruction manual and other documentation in French, which was never available before. So even if they can't, most of the things are numbers that they're entering, so obviously that doesn't, it's not relevant. And some of the other things where there is words that could be in French, those ones are translated, and it's a click thing, so they would click the box.
Multi-select, yeah.
Okay.
Yeah, the menus and
the selections will be in French. So it is pretty much French, I would say.
There's very little pre-text.
Yeah. And if they have difficulty, like, do they contact you, or like they
contact her and contact me, and contact them, and
like you help them?
Oh yeah, okay. Of course. Talk to them on the phone and everything, whatever.
She calls on our behalf, absolutely.
So I'll just finish off by giving a couple of, if we can advance that, just a couple of really simple uses of the registry, which we all are quite familiar with already. There was the whole, I'll come to the uses. So the registry data, we all know this, it's now published both in paper form and on the website. We've also got clinic-specific data on the website. We talked about that whole transparency issue from a couple of years back. And we also generate clinic-specific reports that are private for just the clinic, so that gives them a bit more detail that they can compare to the national average. And then, so I'll just finish off by saying, a couple of things that we're familiar with. Kaleido. The registry was useful for the Kaleido in supporting Vertex's data requests and also in getting us access to this drug.
Now I'm going to be asking questions. Now, are we registering patients on Kaleido now in the data registry? Yes?
Well, they can indicate that they're taking the medication.
Yes, okay.
And then, of course, newborn screening. The registry was quite useful in supporting the clinical study that Denise is working on now and for getting the provinces up to speed.
Yeah, and on that topic, John and Angeliva, Quebec, we'll have to plan a meeting around that. the newborn screening.
So I'll pass over to Denise, who's going to walk us through. Show us
For
the
sure,
screenshot.
absolutely. So I'll just talk briefly about some static screenshots that I guess none of you will ever get a chance to see. So it's a URL link now, it's completely web-based. It's CanadianCFRegistry.ca, and this is what the world will see. This is what the public sees, what you guys will all see, and it's simply a login page with a little bit of summary of what the registry is, and if clinics need to get access to the system, they come to us, sign a confidential agreement form, and then we issue them a username and password. And then they only get access to their clinic. So a nurse from St. Mike's will only get access to St. Mike's patients. All right, so sorry, there's a little cumbersome here. So the first thing they'll see when they log in, which is the, I guess, a huge feature, is that they get this snapshot. We call this a dashboard. So these are four big graphs, which shows the health of their clinic, right? So you have here on the top left, you have the age and gender distribution of your clinic. You have a microbiology distribution, and on the bottom two, you have your nutritional status, which is BMI or BMI percentile, and then the bottom right, you have your lung function. So here's a real-time graphical snapshot of what's going on in your clinic at any given time. So if you get access to an actual patient, you come to what is called the patient profile page. So here we have key indicators related to that patient, things like date of birth, their gender, mutation of their genotype information, and this bottom part, this graph here, this lung function over time, which is a really cool visual representation of what's going on in the history of this patient. So instead of seeing just numbers over time, it's just easy to see visually how things are going. And then there are 3 data entry points, which we're talking about what's available in French. So you see here we have the patient information, which are entering patient-specific data, such as the date of birth and location, their employment status, things like that. And then here on the right, top right, we have the annual data record. So these are yearly health metrics that we ask clinics to enter on behalf of patients. So things like clinical measurements, what medications they're taking, treatments, complications, things like that. And then finally, transplant data. So if they've had a transplant, they can indicate there the transplant information. So here, just walk through one static page of what it looks like to enter in patient information. So here is a long form. You enter there are a bunch of questions, and the clinics enter in their responses. So essentially, there are some questions that are required, things like gender and date of birth, and then other information we ask clinics to fill in as their information becomes available. All right, so what we think is the biggest change or the biggest update to the system is what Ian was mentioning before, which is the capability to do custom reporting. So previously, they enter in data, and there was no way for them to pull the data back to them without contacting us. But now they have the ability to design and build their own reports. So that means they're able to generate reports. Here you can see this is just a midway snapshot of what it looks like if they're building their own custom reports. They can generate a bar graph, which is what we call a column, line graph, a pie chart, a patient list, or even tabular format, summary of their patient information. So for example, they want, what they get a lot is what patients have a particular mutation. For example, there's no way for them to do that on their own beforehand. No, they can. Or if you want, say, a filter on, only male patients between the ages of 20 and 25 who have CF-related diabetes. How do they do that? They can definitely do that. And then here you just say, you put in your queries, put in your filter, and then you indicate when you generate patient lists, depending on the data that you want to pull, I want to see first name, last name, and their birth date, and then you can generate all that on your own. So the really neat thing for us as well is, for example, another example of what you can pull is the genotype distribution. So if you're familiar with the annual report, this is the same format as what's seen in our annual report, but this is specific to the clinic. So this is really interesting for them to be able to do it specific to their clinic and identify something that they would be interested in. So this is St. Mike's. So see here we have the pie chart for the distribution of, the breakdown of the genotype here in the pie chart, and then the top 10 list of mutations for that clinic. And then next we have, which is really cool, is if you might be familiar with some graphs from the annual report. So now the system will generate the annual report, the national annual report, in the system, and this will make it amazing for us because the graphs will be available, but they'll be available to the clinics themselves too. So that information is now freely shared amongst everybody. That's it for me. Next, yes.
Sorry, quick question on that. So, and you think that's in real time? So
It's completely real
at any point,
time.
like after whatever they've entered that day, those graphs can be updated based on that
Correct.
information?
Correct, completely, yeah. Yeah, which is great, yes.
So I just submitted a patient input submission to the new implications for Kaleido, and one of the things I put in was the graph that showed weight and FEV1 over time of when they started taking Kaleido, which was a really great demonstration of how the product works. So I saw in there that you had the graph with showing was it lung function?
Yeah, or you mean the patient, that's, yeah.
Yeah. So is that something that can be shared with us? So patients who wanted to submit in the patient input has said, well, you know, when is this due? Because I need to get this looked with my clinic to get this information. So would it be something that patients can request from their clinics, or is it something that if patients tell us that they agree for us to have the information, that we can ask you?
Pull it on their behalf?
Is that something we can do for the future patient input submission? What do you think?
If patients are asking for it, or
so I had some patients who said, I really like to contribute to the patient input submission. I need to make an appointment with my physicians to be able to give you the information you require, which is my FEVs and my weight at the start of treatment and during medication. So is it something that we can ask you for?
So yeah, to bypass going to the clinic, so the patient can say, we consent CF Canada to pull our records on behalf of the patient to submit for these patient input submissions.
So it's data that's already in there.
Yeah.
It's data that's already in there.
So the clinic can pull anyway, right?
If it's their data, their own personal information, just to show the graph, it probably would be something that you would have to do,
clean up,
and program yourself. The difficulty is that we don't have the exact dates at which they start the medication, but if the patient knew the date, then we could look at the lung function before and after, and those are more sort of specific tailored reports that could be generated, but they'd be one-offs. They're not ones that would be a standard report that we would have in the system, if you know what I mean.
Yeah. But okay, that's a good question.
Yeah. And even just sort of highlighting some of the changes, you know, I think, as Norma, you pointed out, that there aren't a lot of data registries that date back this long. I mean, this is really one of the only ones, the CF one, both in the U.S. and in Canada, that dates back to the 60s and 70s. So that's unique about it. And a lot of registries look to Cystic Fibrosis Canada and in the U.S. for how to do this. Like, you know, they've previously contacted Mary and they contact me to say, you know, I want to create an osteoporosis registry across Canada. How do I do that? Or I want to, you know, sickle cell, because people are living longer and now they're transitioning to adulthood, and we want to be able to create a database and getting information about that. Especially diseases where it's relatively small numbers, this is really, really useful, because if you have something like cardiac disease, you know, heart disease, there's so many people who have heart disease, you can just look in one little location and have a ton of people, right? But in CF and these other diseases where there's a small number of patients, the power in this is that we can look across the country and have 3,000 patients or 4,000 patients, as opposed to if we were just looking at St. Mike's, we're talking about 400 people. Well, that's a bad example. 400 is actually quite a few. Yeah. But say we were in Hamilton, we would be talking about, you know, 100 people or 50 people at some of the clinics. And you can't really say a lot because the numbers are too small. Certainly about survival, you can't say anything about that kind of stuff. So I think that's really, really important. And when the registry started back in these days, you know, literally, you can have a look at this after. It is interesting just to see the kind of stuff that they collected. Really, it was kind of the demographics, you know, gender breakdown, birth information. Back in 1976, they didn't even collect information on lung function and nutrition. That came a little bit later in the 80s. So as the registry has evolved, we've added more and more things that we know have become important to the registry for clinics to enter information. And sometimes you don't know what's important until it happens. An example is CF-related diabetes. When the median survival was in the teens or 20s, nobody really had CF-related diabetes. Now, in adults, 50% of patients can have CF-related diabetes. So, in the early days, they wouldn't have even thought of it. Then we sort of entered it in and thought, as a complication, do they have diabetes? And we had that as a variable, but there was no date of diagnosis of the CF-related diabetes within the registry. And we realized later on that that was important because we needed to know when it occurred, because certain things would be different depending on when it occurred. So we added in the date associated with that. So these things have evolved.
Now, do you look at the date that they're diagnosed, or do you look at the date in which there's, because I think of Kingston. I know the doctor.
Richard Van Wyler?
Yes, Richard was saying that he could detect that a patient or at 10 years of age was going to be developing diabetes.
Right.
So do you go that far or only at diagnosis?
It's at diagnosis. So they could meet clinical characteristics for diagnosing CF-related diabetes, and it doesn't matter if they're on therapy. I mean, we have some people who have diabetes that therapy is tricky, or they're refusing it or whatever, but they have diabetes. So the date of diagnosis is what's important. But there are different levels of diabetes. There's impaired glucose tolerance, there's all these other things. We're just sort of focusing, when a doctor has said you have diabetes, that's the date that we want. Another really good example is transplant. In the original database, there was no date, or there was no information of transplant. Of course, when transplant started, there was a little box and there was a date. So that was the transplant date. But there was no organ, because of course, someone's being transplanted with lungs, right, in CF. But now we know that there's, liver lung, there's heart lung, there's bilateral lungs, like just the lungs. People are living long after transplant that they require a kidney transplant later on down the road. So there's all these other things, and it became clear that we weren't tracking the right things, so we added in an organ field so that people could indicate what it was. Because prior to that, we would look at the data and see, why was someone with an FEV1 of 89% having a transplant? Well, because they had a liver transplant, not a lung transplant. But we had to go back and clean up all that data. Now it's more clear in the registry what the transplant. So those are just sort of things that have evolved over time in the registry, and I just wanted to highlight that all of those things don't date back to the very beginning, because things have changed as we've moved along. So this is obviously the registry report. We no longer use the typewriter. It's very, looks a lot nicer. In fact, in the past, these reports, part of the problem was the clinics would spend a lot of time entering in information, and they wouldn't get anything back until like a year and a half later after they'd enter in the information, because that's how long you had to wait till the end of the year to start generating the report. It would take a long time, and they literally would have, at the Canadian Clinics meeting at the North American CF Conference, Mary Corey would come and kind of give a couple of graphs on one of those, what are they called? The overhead? Yes, the overhead thing, and show a couple of graphs, and that's all clinics got. So, it's, I think, a real advance that the clinics see the data and they get information back. And now they can see all these great graphs. They can use them. Clinic directors can email and say, or now they can generate their own, but they can use these for presentations. Instead of using graphs from the USCF Foundation, we really want to encourage people, when they're talking about stuff in Canada, is to use the graphs from the Canadian CF Registry. So that's been a real advance. And again, this is the graph that shows basically the age of the patients on the x-axis, and on the left-hand side, the number of CF patients at each age, and for 2013. And right away, you look at this graph, and you can see that people are living into adulthood. If you look at the sort of above 18, most of the bars are to the right. So people are living a lot longer. The distribution and characteristics of the patients have really changed over the years. And we have people at St. Mike's that are 60 and 70 years old who have CF. And every time I tell somebody, oh, I'm a CF doctor, they think, oh, you work at sick kids. But obviously, that's not the case, because it's still very much seen as a pediatric disease, which has to be for some reasons, especially fundraising. It makes a difference, I guess. But it is important to recognize that the adult population is bigger than the pediatric population. And in terms of fundraising, kind of trying to give that message, use that message to help fundraise, it's important to say that this is a chronic disease now, really. People are living with CF for their entire lives. It's not the same as before where, we have patients at St. Mike's that said, I didn't think I'd have to finish high school because I thought I'd be dead by then, and now I'm 45 and I have no education and no job and I'm on disability, even though my lung function is 80%. So, people are living a lot longer with complicated diseases that affect multiple organs, and that they have to manage working, having a family, doing all their therapies, staying out of the hospital, or coming into the hospital when they have young children at home or a full-time job and they're at risk for losing their job. They don't have, so there's all the depression, anxiety, the thought of a transplant. It's a different sort of mentality, but we can't forget that adults are really important in all of this and are living with a chronic illness that is really impacts their lives, especially when the therapy just to stay well can take 3 hours a day. I mean, really, when you talk to patients and say, what time did you get up this morning? And I got up at 4:30 so that I could have my masks and do my therapy and blah, blah, and get to work on time. It really makes a big difference.
So going back for a second, this is my big question. So obviously you see post-30 years where you see the drop-off.
Yeah.
And I know this is a transition, and we're talking about transition and enhancing adherence. What else can be done to lift?
Well, this is, really we would need to look at some other metrics like lung function and nutrition and how that does decrease over time and decreases in adulthood. And at times of transition, like the age of 18, when they move from pediatrics to adult clinics, that's a vulnerable time. People can get sick. They have to go to a different hospital. They don't know the team. They sometimes avoid us. I don't know why. They shouldn't, because, but they don't know the team as well. And so, you can see these times where the lung function sometimes can go down. This is just the age distribution alone of the patient population.
It's one time, it's for the...
And it's one thing for the year, but if you look over time, you can see these particular points, So this is just talking about the fact, what I just said, there's more adults than kids. And that used to not be the case in 1990, where the pediatric population was much greater than the adult population. And without numbers, as Ian said, you know it's true, but without the actual numbers to show somebody, it's not as powerful, and that's really one of the big things about the registry data.
Can I just go back for a second? Like 2007 with the newborn screening introduction. Just want to see, I mean, you don't have a number of patients total on each group as well, but
no.
But you do, I mean, at the closest, and especially in 2007, you see a drop a little bit more.
I mean, I think newborn screening definitely will identify more people with CF at an earlier age. So we might see more pediatric, like a bump in the pediatric numbers. But it's probably not as great as the number of adults that are living longer. So it may kind of not, it may be washed out a little bit, diluted a little bit. You'd have to look at the specific numbers for newborn screen patients. So I want to just show you how the registry can be useful. It's useful just to summarize the data, to be able to talk about numbers, to understand your patient population in Canada and your clinic. But it's been used for research in the past, and actually this is the first time that it was used to show something that was incredibly important and is still actually referenced all the time, this paper, and it talks about the enzymes. So basically, you know how patients with CF they need to take pancreatic enzymes to digest their food, most people with CF. So about 85% of people will need to take enzymes to digest food. If they don't take enough enzymes and they have a piece of pizza or a high-fatty meal, they get abdominal cramps, bloating, and bad, greasy stools. So it's not pleasant for patients. Actually, compliance with enzyme therapy is probably the best of any treatment that we give them, because it really is not a very pleasant situation for the patients. So in order to minimize those symptoms, back in the 60s and 70s, they said, eat low-fat meals because that'll decrease the chance of you having those complications, because the enzymes were not enteric-coated. So they would eat them, and the stomach acid would break all of the enzymes down, so they never got to the small intestine where they needed to be to absorb the nutrients. And it's funny because as, you know, an adult now, I look back, and when I was about 14, no, maybe even younger, 12, 13, God knows these parents, I think you've heard the story. I babysat for somebody down the street, Ann and Tony Errol, and they had three kids at the time, and their oldest son had cystic fibrosis. And of course, you know, what do I know? Nothing about CF. I'm 12 years old. I go down there. There was like a cup this big filled with pills to take for before his bedtime snack. He had a mask that he had to sort of do this solution, the board, you know, so you do the clapping, and somehow they felt it was okay for me to look after and go out, which is really quite shocking, because after I had kids, I'd be like leaving my adult brother with my firstborn and saying, are you okay? We're just going down the street, and you can call anytime, and meanwhile, he was healthy, you know. So it's kind of crazy, but so that was my first experience, but the number of enzymes, probably 30 pills that they'd have to take with any given meal. And but Dr. Crozier was the director at Sick Kids, and he thought that malnutrition was bad, and because people had to have low-fat diets, they were often malnourished, very skinny, and you know, had no extra fat, and their growth was stunted. So people were short, and they were really skinny. And he thought, you know, I think actually growth is really important to survival and outcomes in CF. So what we're going to do at Sick Kids is we're going to give a high-fat, high-calorie diet, and if you have to take 35 enzymes with your meals, that's what you have to take. So you just take it, and we're going to aim for normal growth and nutrition. But the rest of the world wasn't doing that at the time. And so he did that for several years, and Mary Corey, who is the one who basically kind of started the registry here, who was at Sick Kids at the time, and was a researcher there, she published this paper which essentially was using the Canadian registry data and also the data from Toronto, because at the time, you know, that's where she was. And she compared the outcomes, particularly survival, with a Boston clinic that had very similar patient population. And this is the survival graph, Ian, as you pointed out earlier, also called the Kaplan-Meier curve. So it all, which I thought for sure you would know listening to us talk about that. And the yellow line is Toronto, and then the blue hashed line is Canada, and Boston and the U.S. are the other two. And you can see right away Toronto's survival was 9 years on average. Median survival was better in Toronto compared to Boston. And not the only difference, this study was not designed as a randomized trial saying you're going to have high-fat diet and you're not. It was just a retrospective study, but the main difference between the clinics was the high-fat diet and the approach to nutrition. So that's where it came from, what you're talking about, was that after this was published in 1988, essentially the rest of Canada got on board. The U.S. was probably a decade later before they kind of all got on board, and I'm just estimating these numbers, and the rest of the country. Now, of course, that's standard of care, right? Standard therapy, we give people high-fat diets. We even give people who are pancreatic sufficient who have BMIs of 32 high-fat diets, which maybe is a little bit off, but we have to revise our approach probably to certain patients. But this was critical, and the only way this study could be done was because they collected data longitudinally over time in the registry and in the Toronto database. So fast forward a couple of decades, because really, Mary was really the only one who used the data in the past to do research. It wasn't readily available. It was in a SAS data set. It was cumbersome, and people couldn't access it. So that has changed over the years, and we thought that it would be good. We know survival's increased because we publish it every year in these reports, right? We know that survival is increasing. But that's just a very basic a look at the survival. It doesn't account for other factors. So we wanted to take the registry data and look in a contemporary group of individuals. What's the survival, and are there any predictors that will predict who's going to have better survival versus not? And publish it, because people always quote the U.S., right? They always quote the survival in the U.S., and it's not applicable necessarily to everywhere else. So we published this paper in 2014 in the fall using the Canadian registry data, and this is showing, as we've seen in the reports, the survival has increased. So this is just median age of survival over time, and the solid line is the overall group, and then the other two lines represent males and females. So right away, you can see a couple of things that basically survival's increased. So this ends in 2012 because the paper used data up to 2012, but we know it's over 50 now. And that's the median survival's gone from 32 to almost 50 in that time span, which is quite remarkable. Not many diseases have seen that degree of improvement in survival over time. The second thing that you can notice is that there is a difference between males and females in terms of survival, and we don't know exactly why that is. No one's been able to sort that out, but it still exists. People previously thought maybe it was the gap was closing, but you can see that males, for whatever reason, live longer than females with CF, be it access to care, like maybe people they're healthier, maybe females have worse bacteria, maybe there's a hormonal influence. I mean, there's lots of hypotheses. No one's really shown why that's the case. And
sorry, is there work being done in that area right now, trying to figure out what's causing that?
There's some. I know Neil Sweezy at Sick Kids has been looking into the hormonal influences.
Who's doing that?
Neil Sweezy?
Oh, yes, okay.
The other thing that's interesting is just you can see that the survival actually was relatively stable until around this time period. So, the graph is relatively flat. So again, you can kind of look at that and say, what happened in 2000 that all of a sudden now it's basically going straight up? Without the registry data, we'd have no clue what the survival was doing over time. And that's important because then you can look back and say, okay, well in 2000, that's kind of when Pulmozyme started, transplant started in 1989, maybe that's kind of influencing things, because transplant is one of the few therapies that can actually impact survival immediately, right? You get a transplant or you don't, and you might die. So Kalydeco is a great drug and an advance in CF. We're not going to see the impact on survival with that medication for decades, because it's going to take that long for the people to be at the age where they actually are at risk for dying. And one of the other reasons that I think the survival has increased is that study I told you about nutrition, in the 70s and early 80s, people born with CF in Canada were exposed to good nutrition from birth. So that makes a big difference. You're not catching up. You're not being diagnosed and kind of, on a low-fat diet and really cachectic and losing weight for years and then have to gain all that weight back. You're kind of exposed right away to good nutrition. So those people are now 30 and 40 years of age, which is, they potentially could be at risk for dying, but they're not dying. So that's kind of pushing up the survival as well, although we haven't proven that in a study, but that I think is one of the reasons why survival in Canada anyway has increased over time.
Do we have a breakdown, let's say even like the transplant, I guess you're going to transplant?
Yeah.
You are?
Yes.
Okay, so.
I'll come back to you.
Okay.
Yeah. So the impact of mild disease, one of the things based on that graph I showed you, that was everybody, right? So of course people said, well, it's going up because we're capturing people with milder disease, because we have genotyping now, we have newborn screening wouldn't impact it, but let's just say newborn screening, so you're diagnosing people who have mild CF, and that's why your survival looks so much better, because in the registry you're capturing those people. So we looked at that, and in fact, there wasn't any change in the percentage of people who were diagnosed as adults. You might think that those are milder cases, right? If you don't get identified as having CF until you're an adult, you probably have mild CF. Then we looked also at the proportion of people who were homozygous for Delta F and who were pancreatic insufficient, because those are two factors that you would say is a marker of severe disease, right? So if those are going down, which they are, but it's small, like you can see, the proportion of people who are homozygous went down from 49.6 to 48.9. That's not going to cause a huge jump in survival. But it's playing a role. So, and then also just we looked at some of the milder mutations, and yes, we have identified more of them. And we redid the survival analysis with different people. So basically, if you look at the bottom line here with the hash marks and the squares, those are people who were diagnosed before the age of 2, and you can see that the survival is lower for them at all points. So definitely, having milder people in the registry is partly responsible for the higher survival, but you can see the graph follows the same shape as the overall graph. So they're getting better too, right? Like their survival is increasing as well. So it can't be that it's only mild cases that are driving the increases in survival, because otherwise you would see that their graph would stay flat. And similarly with the homozygous Delta F, their graph is improving, and people diagnosed under the age of 18. So there's other therapies we're doing that are improving things. So median survival is one thing, but the truth of the matter is that, in Canada, there's probably between 45 to 50 deaths per year with CF, and that is, there aren't a lot of deaths, so it's hard to always look at median survival. There's going to come a day when we can't actually calculate median survival because there aren't enough deaths, which is a good thing. So we need to look at other statistics, and these are some other things that we've looked at in this paper, looking at median age at death. So, and that is basically taking the people who died in the year and the middle age of that group of people. You order it from lowest to highest and take the middle age, and you can see it's increasing. So of the people who die every year, they're dying at a slightly higher age, meaning they're living longer. And then if you look at the death rate, that's the number of deaths over all of the people in the registry that year. That's decreasing. So the rate of death is decreasing as well, which is, again, all sort of positive things. But we can't forget the fact that there are still people dying with CF every year, and the median age of death, this was 2012, was about 32. So, 50% of the deaths were under the age of 32. 50% of the deaths were over the age of 32, and it could have been 33, 34, 35. It tells you nothing about the distribution after that median age. So it still is, possible to use that message. Yes, survival is improving, but there are still really important things that we need to do to help the people who die with CF every year, because they're really young, and it's not, pleasant.
So I know you're probably going here too. So if we break down the reasons of death, infection, waiting or lung transplantation complication, do you have that broken down for this patient group? Off the top of my head, I don't, but the main reason for death is a pulmonary respiratory failure. That's the primary reason for death. I would say probably 80% of patients, that's the reason. I'll talk about transplants as well. We can see how many people died after transplant versus before transplant. Mm-hmm. We didn't previously have information on waiting list time. We now have, since 2011, the date of listing, so you can see when someone's listed and then waiting for a transplant, what happens to them. So if we go... And how many people are actually waiting for a transplant per year across Canada? Would you know? I can tell you that about 25% of transplants are for CF. And in Toronto, I know that let's say they do 100 transplants on average a year, so 25 would be for CF, yeah. But how many of those are waiting versus transplanted is not off the top of my head. I know I'm asking a lot of questions, Trish, but have we also measured... You're cut off, Norma. Okay, more questions after this. Do we know the average time of wait? No. I know it in Toronto is approximately 6 to 9 months. Mm-hmm.
just on average, but across the country, we don't have those numbers off the top of our head, but we should be able to look at that because now we have listing date in the registry and can calculate the time from listing date to transplant. So another paper that we published with using the Canadian registry data was this statistical model to predict 1-year survival of death. And without getting into the complicated details of it, because this particular paper is sort of mind-numbingly complicated, is that this is a way for you to kind of calculate what is the risk of you dying in the next year with CF based on all of these different variables. And that's really important because as a doctor, I want to know if your risk of dying is high, I will think about referring you for a transplant, especially if it's high in the next year. And so this was looking at everybody, not specific to people with end-stage lung disease, but it was looking at everybody. And our hope is that we could then predict, develop a model that is specific to people who have bad lung disease. So we can say your risk of, death is really high, and your risk of death with the transplant actually is this. And so you'd want to actually make sure someone is in the system for a transplant early enough so they get it, and their chance of death is lower than without a transplant. And this is sort of the first paper that is trying to calculate that. Now, getting to this is the last paper I'm going to talk about is just transplant survival. So this paper is coming out soon. It's been accepted in Journal of Heart-Lung Transplant and should be in the next couple of weeks, I think, coming out. But we took all of the patients who have had a lung transplant in the registry, and we looked at clinical and demographic factors associated with your survival after transplant. And we were able to calculate this overall survival, which this is just taking all of the patients. So there were 453 patients who had a transplant in the registry ever, first transplant, and looking at their survival. So 90% chance of 1-year survival, 5-year survival was 67%, and 10-year survival 55%. I think, people think of transplant, it is a big deal, and it is obviously something that is, not to be taken lightly, but people, I don't think, fully appreciate the survival after transplant is actually quite high for the right people. For people who need it, and for people who don't have certain bacteria, it's quite high. So that's one message.
In this information, does it include also one transplant, a second transplant? Do you have those there too?
This is the first transplant, regardless of.
This is only the first. This is not including second or second.
It is transplanted patients, identifying the transplanted patients obviously on the first transplant, and then whatever happens to them after that happens to them. They're included in there.
Okay.
The second transplant, and that was another thing, the old registry had one field for the date. So, now if people are having second lung transplants. Actually, in Toronto, there's quite a few people are having second lung transplants, even third lung transplants. And so we can record the date for each one and look at that. But there aren't enough of them to actually, probably tell. So I mentioned that the overall survival is very good, but there are certain circumstances where it's not so great after transplant. And this is actually a graph showing the survival if you have Burkholderia cepacia, you guys have heard of that, and versus people who don't have that bug. And so you can see right away that if you have cepacia, this is the blue line, survival is not as good. And it is the highest risk in the first year after transplant. So that's important to be able to tell people what your risk is after transplant if you have that bug. And this is a survival curve just showing by decade, because you want to know, are we getting better at transplanting patients? Is the survival better after transplant now compared to when they first started doing it? And it does, although not statistically significant, it does look like there's a trend towards that. So the top one are transplants since 2000. the red line is transplants prior to 2000. So you can see that the survival at each stage is better, although they seem to be coming together in year 5. You see the lines are coming together, but that probably is reflective of the fact that people die after transplant of chronic rejection, which is called bronchiolitis obliterans, and they haven't solved that mystery for anybody, you know, now or in the earlier times of transplant. It's still a real problem, but if you take away bronchiolitis obliterans, you know, and you look maybe earlier on in the 3-year range, it does seem that people transplanted now are doing better than they were before, probably because the surgery, you know, the surgeons are better, the technique is better, the immunosuppressive medications is better, they're better, that kind of stuff. So those are kind of 3 published papers recently, and then that first one I just wanted to show you. And then what we hope to do is not just do a predictive model for 1 year, but look at 3- and 5-year survival, look at people with end-stage lung disease, what's their risk of death, so that we can predict, you know, is it better for you to go for a transplant or not. And then international comparisons, Ian mentioned that graph in 1976 showed a difference. There still is a 10-year gap between the U.S. and Canada in survival. And nobody really understands why that is, but we have a grant from the U.S. CF Foundation, actually, that is looking at that, and we just submitted a poster for the North American CF Conference, because there were actually, we were doing the analysis slightly differently, and when you publish something like this, there are no details about how we calculated that median survival, like from a statistical point of view, because people would be bored out of their mind, and most lay people might not get it, right? So we don't put that information in there, and neither do the U.S. So we sort of thought, well, there's one way to do it, isn't there? But there actually is more than one way to do it. There's different statistical methods, and there's actually different, even if you're using the same statistical method, there are different definitions that go to, you know, who is actually captured in that cohort that might be different. And so it's not really fair to compare directly this report with that report of the UK or Australia. It's not a fair comparison. So part of this study is to say, let's do it exactly the same way in Canada and the US and see, maybe it's not different. So we did that, and it actually is different. So we are a little better, but, you know, just mention. But the more important question is why, right? It doesn't matter if we're higher or lower. It's just, why is it different? Because that will then reflect on the patients, and the registry is important in answering those questions, which is what we're going to do.
Can I ask a question? In respect to the U.S. health services that are provided to patients, compared to Canada?
Yeah, well, that is one of the things we're going to look at. Obviously, the healthcare system is different. The access to care is different. I think that the access to transplant in particular is quite different. There are also some other factors, you know, that come into play because, you know, they may not be capturing all of the deaths in the U.S. We are lucky in the sense that as a relatively small country, compared to them anyway, we can go back to all of the clinics and say, can you tell me what the lung function was in so-and-so, and did that person, are they still alive? And, you know, the nurse is like, oh yeah, or no, they died, or, you know, whatever. So they can't do that in the U.S. There's hundreds of clinics. They just can't.
Well, just for example, what's the cost of a lung transplantation in the U.S.?
In the U.S. So we're going to try and look at those things, and that brings us to the final point, which is the health services utilization in Canada. We've never done that either. I don't know how much it is to treat a CF patient in Canada, never mind the States. So we're going to try to look at that using some of the health administrative databases at ISIS and you know, the registry, linking those two to try and estimate how much it costs. And that's important too with the new medications, right? The cost of those new medications, is it help, you know, decreasing the cost of care? But those are yet to be done studies. And this is basically a slide put together by Denise that shows you kind of what's happened over the years, how the registry was started. You know, the green dots are where there were pretty big discoveries or you know, drugs that became available. And then the blue dots are showing different requests. So I told you back in the early days, Mary was the only one who used the data. to do studies, and now we get more and more people who have requested the data to use for their own research, not just myself, but other people who are using it. And also drug companies want summary data to, you know, they'll be happy to pay a fair bit of money for that. And so that's actually been increasing.
And what you don't realize, like IMS, which is a company that pulls lots of data from sources for pharma companies, charge a lot of dollars, which is, I mean, we are...
We're peanuts for them, okay.
So, we need to think about that moving forward.
Yeah. I mean, the drug companies don't get patient data. So, you know, just so we're clear, researchers will get individual patient level data. Like I'll get each, not their names, but I'll get, you know, patient 102 has this lung function and this and that height and weight. They don't get that because that's not appropriate, but they'll get summary data, like how many, what proportion of patients have this or have that, or, you know, sort of
averages,
yeah, not patient level data. But it's important for them still to understand, and they're keen to get it. So that, I think, my thank you slide. You know, and then Ian, I think, wanted to maybe thank you.
Yes, thank you very much, Anne. Thank you, Denise. I hope this has given an impression that this registry is a big deal. You know, it's kind of a big deal. It's been going on for a long time. And the new registry, which was sort of the point of all this, it's been years in the making. It's had a tremendous amount of work put into it. I mean, obviously, Anne and Denise, we've had focus groups, we've had nurses involved in this, a number of clinicians. So this has been tailored to the community so that it's as most valuable to them as it can be. There are also a number of other people that I think we you know, deserve a vote of thanks for their help in it. Obviously, Ken Chan had spearheaded this whole process. Sophie for making it be French, which is, as I said, the first time that our French-speaking colleagues are able to use it. And of course, Jackie Ruderman, who had the monumental task of taking the old system and moving it into the new with the business case proposal and all that whole process, which was a staggering feat of project management. We owe her a debt of thanks. And thank you all for coming. So if there's any questions,
Well, one final thank you. This is outstanding. So thank you. And thank you for everything you do. It's fabulous. I mean, your passion.
I love it. I love my job. And I love being part of it. But if anyone ever does have questions, obviously you've got resources here, but I'm happy to.
Wonderful. And I'm just thinking it might be worthwhile. Are you take this?
we have.
We have, eh? Because I would love to be able to send this to the board of directors. I think this would be extremely informational.
Yeah.
And I mean, they have a good idea, but this will provide more insight, particularly for the newer board of directors that have recently joined us.
Right. Yeah.
Thank you, everyone.
Thank you.
Thank you.